ClinEpi round. So today we have a thesis proposal defense. Kieran Quinn, who is a PTY 27, something like that, many years of training, is going to be presenting to us on the role of palliative care in non-cancer illness. We'll present for a relatively short period of time, following which there will be questions, and then the faculty will be asked to stay and have a big powwow, and the rest of you will be asked to leave, and that's the hour. So Kieran,
thank you.
Take it away.
Thank you all for coming out on a busy and snowy Friday. I appreciate all of your support and being here. So as Marie said, I'm Kieran Quinn. I'm a general internist and I practice palliative care in Toronto as a clinical associate at Mount Sinai Health System. And the focus of my thesis research is to evaluate the role of palliative care in non-cancer illness. Here's a brief outline of how I'll spend the next 20 minutes. So as you can see, it'll be fast and furious. And up front, I'd like to just acknowledge the generous funding support that I received from various organizations. It helps with 3 kids and a mortgage to be able to be funded for my research and make sure that it's feasible to complete. So the overall goal that I have for the research that I'm doing and setting my path forward from this point is to really measure what association exists between the receipt of palliative care and important policy and patient-facing outcomes. And I'm really particularly interested in focusing on those for individuals who have non-cancer illness. Briefly, the story that set me on this path actually began as a first-year internal medicine resident one night when I was caring for an older man with advanced stage dementia on call. And he'd come in from a nursing home and had been hospitalized countless number of times in the past year and was near the end of his life. And over the course of the 5 years of clinical training as a resident that I had, I noticed that there was a difference between the end-of-life care that people with cancer received compared to the end-of-life care that people without cancer received. And that bugged me for a variety of reasons. And as one of my supervisors said, do the things that bug you or look into them. So this has actually become my passion in research, to figure out if we can improve end-of-life care for these folks. And so I'm proposing 3 studies to complete my thesis, my PhD, and they are nested within the National Consensus Guidelines on the 8 domains of palliative care that I've outlined here. And in order to stay focused and answer important questions, my main interest really is in the structure and the process of that care delivery. And I will examine some of the other domains you see highlighted green, but obviously cannot cover all domains at one time with focused research questions. And so I propose that I will present a study that is a systematic review to begin, and then 2 cohort studies, which I'll take you through today, the details of their design. First and foremost, palliative care is typically and traditionally recognized delivered to patients with cancerous disease, and you see in the purple slice of the pie, that represents about 1/3 of people nearing the end of life who have palliative care needs. And what most people don't realize, for a variety of reasons, is that actually the cumulative sum of all of the other individual diseases that are non-cancerous in nature comprise the large majority of people who have palliative care needs at the end of life. And that's the gap that I think exists or is beginning to be examined in the palliative care research sphere to help these types of folks with their end-of-life care and meeting their needs. Then there was a seminal paper in JAMA a couple of years ago by Dr. Cavaliatos, which Camilla Zimmerman, who's present here today, was also a co-author on. And this really reviewed the state of the evidence for palliative care and patient and caregiver outcomes. And what they highlighted was that of a variety of needs in the palliative care sphere, we don't understand the individual efficacious components of palliative care as a complex intervention. And with respect to my particular interests, there's a huge need on evaluating its role in people with non-malignant illnesses, as Dio refers to it, but non-cancerous illnesses like heart failure, COPD, these very, very common conditions that we see a lot of our patients and family members suffer with. So the first study of my proposed thesis is a systematic review and meta-analysis, focusing on the receipt of palliative care and a variety of patient and policy-facing outcomes. and covers really 4 of those domains, of the structured domains of palliative care as I discussed. And so the focus research question for this systematic review is whether the receipt of specialized palliative care is associated with healthcare use, death at home, and quality of life in adults with non-cancerous illness. So as a traditional systematic review would proceed, I'm aiming to evaluate randomized controlled trials of specialized palliative care interventions, and those specifically in adults who die of one of the 6 most common causes of non-cancer death. That's heart failure, chronic obstructive pulmonary disease, or COPD, end-stage renal disease, essentially people with advanced renal disease on dialysis, cirrhosis, dementia, and stroke. And while we will allow the inclusion of patients in those studies who have coexisting cancer, we've decided on a cut point of an exclusion of studies who have more than half of their patients have cancer, which then those studies are typically geared towards palliative care in people with cancer as opposed to non-cancer illness. And the primary outcomes specifically for this systematic review are to look at the location of death, home, hospital, other locations like long-term care, their healthcare use, so that's hospital admissions, emergency department visits, etc., and different measures of quality of life. And we'll search the traditional medical literature from inception to the present day. And so our analytical plan would proceed as most systematic reviews would. So myself and an independent co-reviewer will go through the titles and abstracts and select those studies based on those criteria I just outlined. And then we will analyze the data through narrative synthesis, a variety of statistical measures to get at the variation, heterogeneity, potential bias in those studies and the quality of those studies. And providing that we have enough studies per outcome, we would then perform a random effects meta-analysis across those different outcomes. And one of the common things that comes up is specifically in those quality of life outcomes that there are a huge number of different scales that are used across different studies. There's really a lack of standardization across the way we wish to conduct these studies. But thankfully, Dio, in his paper, found a way to calculate those into a common theme of one scale, the FACIT-PAL scale, using G estimation, and he's agreed to help me with this study, which is hugely beneficial to be able to sort of standardize the measures in one common theme. So the second study is a different type of design. It's a cohort study, and this will be using administrative data up at ICES across Ontario. And this is looking at the intensity of rate of referrals of physicians to palliative care and how that affects patient outcomes at the location of death. So the specific research question for study number 2 is the rate of physician referrals to palliative care associated with location of death, specifically death at home versus hospital, in a cohort of hospitalized adults who are in the last year of their life. So at ICES, there's a huge variety of linked health administrative databases in which we can measure and account for our exposures, our outcomes, and a whole host of potential confounders through all of this linked data. So it's a very powerful way to measure large populations with a variety of important health information on them. The study design will include all Ontario physicians who are deemed the most responsible physician in that individual's hospitalization episode. And we pair those physicians to the patients for whom they're the most responsible physician. And those patients specifically will have died from one of those conditions that are presented on the screen, the same as the systematic review, with the addition of hip fracture as well in that context. In order to be able to measure accurately a physician's rate of referral in any given year, we exclude physicians who look after less than 100 individuals, simply because it likely doesn't reflect their overall rate of referral to palliative care. And we split our exposure into low, average, and high intensity of physician referral rates based on funnel plot methodology to be able to create those strata. Just to visually represent this sort of complicated data structure, At the top, is the exposures, the measuring the intensity of most responsible physician referral rates. Those are the physicians across, stratified into low, average, and high. And then they are paired with the patients to whom they are the most responsible physician. And that's how the data is nested. So you have individual patients who are nested within physicians, who are also nested within facilities providing care to these individuals. So a multi-level data set. Primarily, I'm interested in the location of death of the patients who they look after, so whether that's at home, in a hospital setting, or in long-term care. But also, I'm interested to look at the influence that the actual center itself may play on the referral patterns and how that affects patient outcomes, and also to measure the actual variation, to quantify that between physician rates of referral, how much do they actually differ. Because it's a multiple level data structure, we'll use mixed modeling, and it's going to be a multinomial logistic regression since there are 3 possible outcome locations. But as I mentioned, the primary outcome of interest is home versus hospital. And the primary exposure, of which there are 3 levels, is high versus average intensity referring physician rates. Again, because of that, the way you think of the data structure, the patient is the primary unit of observation there. We cluster by the physician identification and the facility or hospital number that identifies those to account for that sort of clustering effect. And then we also calculate an individual's pre-test probability for being referred to palliative care as sort of a high possibility or probability or low probability based on a method. I'll describe how we do that using propensity score. And then, of course, we're adjusting for all the different important potential confounders at both the patient, physician, and institutional level. So an individual's probability of being referred to palliative care in the first place is estimated on a propensity score in which the outcome is receipt of palliative care. And these predictors that we think are the most important predictors that influence a physician's decision or a patient's probability of being referred to palliative care. These are the different levels, covariates, and confounders that we are addressing and controlling for at the patient, physician, and institute level. And I can come back to that at the end of the presentation if you'd like to look at them more closely. And then there's a few different pre-planned subgroup and sensitivity analyses that we plan to do both in cancer versus non-cancer diagnoses, which is my area of interest, whether the physician specialty itself has significant differences between, say, surgeons and non-surgical physicians, also whether physicians are palliative care specialists or not. And then whether the patients went for hip fracture surgical repair versus non-surgical repair, as well as different types of referral rates in the ICU itself. And then to validate our findings in a couple of different sensitivity analyses, based on the way in which we measure receipt of palliative care, we'll adjust the threshold of that timing of receipt of palliative care, as well as the means by which we identify the MRP. So the last study is another linked health administrative data study, a cohort design looking at first-time users of palliative care or first initiation of palliative care and health system use in the location of death. So the research question for this matched precedent cohort study is whether newly initiated consultation with palliative care compared to those who do not receive palliative care consultation, whether that's associated with different rates of healthcare use, hospitalization, emergency department visits, ICU admissions, and that's in a cohort of individuals in the last year of their life who are dying of non-cancer illness. Again, to visually represent sort of this study design is also somewhat complex. So we start at the far right when people die and define their cause of death, and we go back a year as their sort of baseline entry and match them on a variety of different factors so that those individuals look as similar to each other as possible, and then follow their exposure over time and the risk of those outcomes that I discussed. We use the same set of linked health administrative data up at ICES. And so specifically, we're going to include adults who died of one of the 6 most common causes of non-cancer death. As well, we'll include cancer in that cohort, but specifically, that is a secondary subgroup analysis to help address possible indication bias in those people who are referred to palliative care, but they're not included in the primary analysis. We look back a year prior to the year prior to death to see if somebody has received palliative care and exclude those individuals who have. So this is sort of a new user design of palliative care. And our exposure is that consultation with palliative care compared to non-receipt. And we will match both directly and propensity score matching on a 2-to-1 fashion on the exposure. Our primary outcomes are the rates of healthcare use over time. And there's a variety of secondary outcomes you can see there that help explain some of the possible mechanisms by which these primary outcomes are derived. Because most of those all of those primary outcomes are rates, we use Poisson regression to calculate their association. And then some of the secondary outcomes are linear and logistic regression based on the type of variable and outcome. We adjust all those models at the individual level, patient level, for a variety of those covariates I listed previously on the other study. And importantly, in this study, because patients have the possibility of seeing multiple different physicians after that first exposure or being hospitalized to different institutions after that first exposure, we will actually not account for clustering in that in our analytical design based on that understanding. So of course, there's always lots of limitations to a variety of studies that I'm doing. Specifically, the biggest concern with the systematic review is that I expect there to be a large amount of heterogeneity between the studies. We've already seen that, and even Dr. Caballerianos commented on it. But I think in the context of the non-cancer illness literature, that's actually still a very important finding to highlight, that we lack standardization in how we conduct these studies, and that in and of itself is an important point to raise if the heterogeneity limits the interpretation of some of the results that I expect. In administrative data, we don't know the preferences of the individuals, whether they are willing to engage with palliative care or willing to engage in sort of comfort-focused care near the end of life. And so that's a limitation that we have. But one way to address that is to, in a subgroup analysis, take the group of individuals who have more than one palliative care visit as a proxy surrogate for representing the fact that those people may be interested or more engaged in palliative care than those who have one-off sort of consultations. We don't know the quality of the palliative care, which is identified through physician claims, that any one of those physicians is delivering or teams is delivering. And so there is a validated method to identify physicians as palliative care specialists in administrative data, and that at least can sort of help to tease out some of that potential quality issues. And as a study in the United States has just demonstrated that there's potential changes over time in palliative care. It's becoming, it's becoming more adopted in lay practice and in medical practice. And so we plan to split our data into 2 time points to help get those potential secular changes. From a feasibility standpoint, can I complete this thesis? Well, thankfully, I'm privileged to have a really very supportive and talented group of thesis supervisors and committee members who have extensive expertise in all of the fields of research in which I'm touching upon. Thankfully, the research itself is fully funded from independent competitive grants and from research foundations. And then personally, I have salary support from the Eliot Phillipson Clinician Scientist Training Program and as a Vanier Scholar, so that helps me with my research support to make sure that I am supported to finish all of it. From a potential sample size issue, our initial pilot data shows that we have around 32,000 individuals with non-cancer. That's everybody not in the red pie. So these are all individuals who die from those conditions. It's about 32,000. We think that's adequately powered to answer our question. And why is this research important? Why do all this work? Well, I think that the thesis that I'm able to complete will really help to inform the knowledge that we have on palliative care as a complex intervention for non-cancer illness and some of the policy and patient-facing outcomes that I've discussed. I sit on the Ontario Palliative Care Network's Clinical Advisory Council, and some of the work that we're doing to inform the Ministry of Health design. These are some of the questions that are continually coming up about how do we deliver it and where is it effective. And so I think this research will help inform that. And in the second study that I presented to you, there are many different facilitators and barriers to receipt of palliative care for individuals, but the role of the physician as a potential gatekeeper really hasn't been looked at carefully, and I think that study will highlight potential areas of intervention to help increase access to palliative care from one of the barriers. These are the members of my committee and ICE as analysts who have been instrumental so far in getting me to where I am, so I just wish to acknowledge them. And again, the generous support from various foundations that I received. And I'm happy now to take questions, and thank you for your attention. So I think Dr. Zimmerman is supposed to lead this as the official reviewer of my proposal, and then we'll open it up to other individual questions.
So I have some questions that I'll just send you that are sort of minor points. Overall, I think this is a very ambitious proposal, but ultimately, as you said, doable with the support you have and your expertise. And a very interesting area, I might add. One question I had about the systematic review is just about your outcome measure and your main outcome of quality of life using the FACIT-PAL, and you're going to translate quality of life to that. I know it's the one that you used, and that's certainly a good justification for us here, but I think you should maybe think about a way to justify that when you're writing up your thesis and ultimately the paper, why you're using that specific measure, which is a measure that was originally developed for the cancer population when you're doing a non-cancer. So I don't know if you thought about that so far.
That's a very excellent point, and I have actually talked to you a little bit about that already. One of the non-thesis studies that I want to do is actually evaluate all of the different patient-reported outcomes that we're using currently in non-cancer trials and studies that have been recently published, none of which have been validated or derived in end-of-life populations. And there is a growing skepticism actually about some of those tools and the need to develop new tools potentially for this particular population. So it's an excellent point to think about why FACIT-PAL and justify that. I'm not sure that there are any other good tools really for the non-cancer, but I can certainly look deeper and make sure we're not missing any of those important tools.
The quality would be one you could think about because it was developed in a mixed population, was validated extensively, and it has pros and cons, but it was developed not specifically in cancer, which is
right.
FACIT tools for and the FACIT specifically. Validated.
Yeah. Well, thank you. That's helpful.
So that's just one point. Another was for your, and then I'll stop and let it go on to other people. But in terms of your multinomial regression, you said you had three outcomes. One was hospital, one was home in terms of place of death. What the other one was just other, or? So
there are two. It's grouped as other, but there are two actual sub-locations to that. So there's long-term care or nursing homes. And then there are complex continuing care and medical rehab facilities that house complex continuing care. So those are in a separate database.
Okay.
I actually have a slide to show you how those are highlighted, if I can find it. Give me a second here. Okay. So those are the databases and how we determine the location of death. So you can see there's long-term care, which is the CCRS database that I see it, and other is essentially unknown or not in those databases where we can't figure out where that person died. So we end up grouping them into those three locations to simplify sort of the overall conceptual design of it.
And where does hospice fit in that?
Yeah, so palliative care units and hospices aren't accurately captured actually in administrative data as of yet in Ontario. So most of the time, the way that their beds are funded are through complex continuing care or CCRS, like long-term care. But it is a limitation that we don't actually, so it's just a limitation that will be highlighted, that we can't actually accurately identify palliative care units or hospices in Ontario.
Palliative care units, I think, are under hospitals. Because they're in the hospitals, right?
Yeah, but the way that the beds are funded, it depends. So those databases are derived from which way where the beds are funded in the ministry,
Which and maybe better actually.
Yeah.
Yeah.
So But the important limitation to highlight is that we just cannot identify that that person actually died in a palliative care unit or a hospice, which is for most people a good thing.
Yeah.
And it's a limitation of what we have. Great.
Thank you.
Thanks. Other questions from the group? Or comments, feedback? This is a design phase. This is when I can improve it.
I have one or two kind of high-level philosophical questions. The first has to do with this location of death thing. So not only can you not tell where people actually died, but like, are you sure that dying at home is a good thing?
Yeah.
You know, for the kind of patients that we see here, I mean, we've been thinking about this for a long time because I see a lot of patients who have a death here. It's actually not bad compared to what, you know, would happen at home with a lot of, you know, maybe crowding in the environment, a lot of decisions around when to take the patient to the emergency and on it. So presumably the design of your second study is you're looking for good care, and the idea is that additional palliative care will provide a death at home that is a better one. Right. I mean, are you like? I mean, is that?
Yeah. So it's an excellent question. It depends. It's all in the eye of the beholder, I think. So there is a wealth of literature that demonstrates that people's reported preferences in an ideological is for home. Whether that equates to a better death, again, is variable. And even some societies have defined quality indicators of good death as dying at home. But I agree, in some of the patients I look after, it's either not practical, feasible, or it may actually not be as comfortable a death based on their care needs and situation as death in a supervised hospital setting. So I think that that's an important question. The location and the outcomes I'm looking at are based on what the literature states to us for now, but I think it is an important area of opportunity to explore further.
The other question I have, again, which is something that you're not addressing directly, but really bears fundamentally on the question of offering palliative care to these patients is, how do you know when a patient without cancer is palliative? I mean, can you accurately predict their life expectancy? Can you predict when they should be receiving palliative care services when they don't have cancer? Yeah.
Again, another huge question that the Ontario Palliative Care Network is actually looking at. And traditionally, we think that palliative care was based on prognosis or expected survival, which we tried to address in some of the designs of these studies. But more and more people are orienting themselves around palliative care needs. In some circumstances, people are recommending that just palliative care should be delivered when people have symptoms that need to be controlled and quality of life that needs to be improved that can't be met by our existing health system. Other individuals have advocated for, you know, at time of diagnosis of heart failure, for example, or the earlier you can, the better. It poses challenges for capacity building in a system, which is a separate conversation, but the short answer is that there are different ways that you can define whether somebody should receive palliative care or not. I don't think we've reached a consensus overall in any organization or community to say this is the critical time or point at which somebody should receive it. But I think it's an excellent point to raise.
Can I ask how you're actually defining the term palliative care or receipt of palliative care?
Yeah, excellent. Sorry, I didn't get into that in detail for the sake of time. Forget about finding it on the slide. There's a slide, but so it's actually physician claims for palliative care. So there are different ways that you can deliver palliative care. There's spiritual care, there's nursing support, there's a huge number of ways, and there are some databases that attempt to capture that. Right now, we're limited. It's a limitation that we are the most accurate and reliable way that we can capture delivery of palliative care is if a physician bills for it and claims for it. But I recognize that that's not the only way palliative care can be provided.
A specialist palliative care physician?
No, no. So any physician can. There's a set of palliative care codes, and so any physician can build that code, and that would constitute delivery of palliative care.
And do we know whether people utilize the code well across these specialties? Because I'm a nephrologist who practices palliative care, and I actually don't know any of the codes.
That's right. So that's a major.
585 and everything.
I would get into practice plan and you should know those codes. So I'd be happy to send you a billing primer on how to do that. But
I know that they're there, and I know which page they're on.
But you raise a very important point. the risk of misclassification in a research context, that there is palliative care that is being delivered even by a physician that is not captured in the methods by which we capture receipt of it. And that doesn't mean it's not happening. It just means that we can't capture it. And that might bias you towards the null or bias you away from the null, depending on the characteristics of the person delivering.
I just wondered if within your specialties, because you've got some nice specialties there where I suspect you've got an informative bias.
That's right.
And that was why I was asking the question, if there's information around that information.
All we can do is separate whether a physician is a palliative care specialist based on the quantity of palliative care codes they fill in a year. Again, it's the limitations of the data that we have, but we're working with both guys. An important point, I agree.
Is there a reason that you focus on the patient having had an inpatient experience, an inpatient physician, as opposed to, in our experience, there are a lot of patients referred to palliative care through their primary care practitioner. I don't know if it just really makes the analysis crazy, or if there was more of a theoretical reason to.
The practical reason is sort of study what you know, and as a general internist, I practice almost exclusively in an inpatient setting. So I'm not sure I would be able to explore the nuances of community care that family physicians face when they're trying to make those decisions and access issues. So that's part of the reason. It's just a practical one about, I understand how patients work within a hospital much better than a family physician in their office. The other way to think about it is in sort of the element of risk, or risk of being close to your end of your life. Like, those hospitalization events are typically seminal events in somebody's course to the end of their life, and the risk of dying after a hospitalization event is very high. So we're looking at some of the quote-unquote highest risk individuals, but it's not to ignore the important.
Right. Because really the outcomes then are for patients who had an internal medicine admission to hospital, what their, it's much more about that, because there may be, you'll miss the patients for whom they had palliative care consults that just didn't go through a hospital. Yeah.
I'm not sure. So in the second study that looks at physician variation, that's just hospitalized individuals.
Right.
The other study is not anchored in hospitalization.
Okay.
It's just anchored in the last year. Right. So there is, and we do measure the location of that initial consultation.
Okay.
Good. So, Rob.
Can you maybe talk about the attribution of the most responsible physician towards sort of the decision making, or the consultant, like in a hospital setting where you have like 20 different doctors, maybe even a nephrologist, and how to nail that down. And I'm not sure. Do you mean the identification of who the most responsible physician is? Yeah.
Is that a good question?
So you're going to look at variables that sort of you're looking for the association between sort of getting palliative care or not. Like, you kind of mentioned that you were going to try to nail down the most responsible physician, or one most responsible for that period of care. Is that right?
That's right.
Yeah.
So recognizing that other physicians who are co-managing or are involved in a patient's care may identify or even refer on their very own will to palliative care. So that is a risk of misclassification, again, that is a limitation, potential limitation. But typically, most patients' decisions and care plans are the responsibility of the most responsible physician, and often the recommendations for care are made by the consulting services, but not necessarily enacted by them. So
if you see, like, if you have someone on service, then Murray was to come on, then Heim was to come on, and then Alan was to come on,
right.
I don't know, over the period of a month, how do you deal with that?
I see, yeah. So the way that that's sort of getting at the method by which we identify most responsible physicians. Sorry, here we go. So you're right, it reduces the possibility or minimizes the influence that Alan comes on for a week and refers that patient immediately to palliative care when I've been on for 3 weeks and I didn't do that, for example. So I wouldn't capture Alan's referral in the way we've designed it. But we've designed it such that we said that the person who is the most continuous in that individual's care probably has the largest impact on making those care decisions and the inertia to start those processes going. Recognizing that other situation exists, and we would miss that in our study design. But we wouldn't be able to then get at an individual physician as a potential gatekeeper without the way that we've set it up. Yeah.
It's more of a futuristic question. So you talk about, looking at what you're trying to get the current context in terms of what's going on, what services they're using, but it doesn't really sort of build on the comments from both Marie and Phil around the quality piece. So I'm just looking at, because I just did a board meeting yesterday, and the palliative care metric that's going across all sectors that is recommended, it's not mandated as of yet,
right,
is this early identification of needs of palliative care patients. So thinking ahead, how might you look at, because maybe the outcomes might not be the most relevant for the people who are receiving care and caregivers. So from a policy standpoint, because you mentioned it, where do you see this work or your program area of research moving towards, possibly contributing to quality outcomes around palliative care?
So I think, the million-dollar question is how to identify people with palliative care needs right now, at least. And I don't think we have an answer to that yet. But what my interest in is, in the context of the policy work in the future, is what are the models that we need or that are optimal, can deliver optimal palliative care? What interprofessional members comprise those teams? What are the limitations across different geographic locations? So this work directly sort of measures and quantifies the association between those two, but doesn't tell us much about the constitution of those teams. What I hope to be able to do with both some quantitative and qualitative methods actually is to get down at the root of that. What Dio commented on in the discussion section that said we don't know the efficacious components of that palliative care. The future that I hope to be able to inform is exactly that. What is the secret sauce, so to speak, that makes it optimal for delivery across the product? And that's going to vary by region, but I think we need to figure that out.
Yeah, and maybe a different type of literature review, like a scoping review, or depending on sort of future out might answer that question. But this is a different question, but I just building on in terms of just thinking about how we can actually look at, in addition to the secret sauce, what are the metrics around that are reflective that mean for those we're providing care to, as well as the caregivers, as well as the healthcare providers.
Yeah, that's right. And even at the Ontario Palliative Care Network, when they were proposing the draft framework on to measure performance at different LINs, there was a huge problem that many of us had with the denominator and numerators of identifying people with palliative care needs was flawed to begin with. So I think the answer is we don't really know how to identify who needs it, and that needs to be figured out, which is another opportunity for future work.
Along those lines, I noticed in your systematic review that you're excluding studies that don't involve interventions that have physicians as a member of the team. I can understand that for your research you're focusing on physicians.
Right.
But for the systematic review, would it not be better to have a bit of a broader focus? Especially if you're going to have a handful of studies probably in non-cancer.
Yeah. So the decision for that was twofold. Let's see if I can find the slide that I'm looking for quickly. So it was around the definition of specialized palliative care, which is essentially created by a couple of different research groups so far. And I'm sure you're familiar with this. But so part of the reason is a practical one to say, well, what did DO do that, and not just to do what that group did again, a few years later. So what is different? In some of the literature, the non-randomized studies in heart failure, for example, suggest that the presence of that physician, irrespective of what that role that physician plays as part of that specialized team, perhaps is important. And so I think that, so part of the reason to do the systematic review with physicians as a team is to constitute the structure of a specialized team and evaluate whether that's an important component or not.
But it's hard to do that if you're not comparing to anything.
Yeah, so you're right. It's not to say that you have to have it, because the research design that I'm proposing doesn't compare to non-physician teams. But the rationale for designing it that way was from the non-randomized literature that suggested that might be important. I don't necessarily want to actually answer that question in this study. It could be a different study to do. Is that important or not? But that was the rationale for including it in the first place. Any other questions? Okay, thank you everybody for all your help.
So, do we have to stay? Yeah.
So everybody is a faculty member. So first of all, thank you all.